Welcome to NAMI Maine Talks. I'm Mary Gagnon. I'm the Senior Director of Prevention and Workplace Wellbeing here at NAMI Maine. And Gordon, so delighted to have you with us today. Would you introduce yourself to our audience today?
Sure. I'm Gordon Smith. I'm the State's Director of Opioid Response in Governor Mills' office.
Wonderful. Thank you so much for being here. And you are here today to talk about the Options Program, which I'd venture probably not a lot of people know about. So can you tell us just a little bit about it, how it started, what it does, kind of how it's grown over time?
Sure. It's one of our really featured projects. And I started work with Governor Mills in February of 2019. So we're just about at seven years now. And the Options Program was announced in October of 2020. So we've had about 5.5 years of the program. And I think we also did a strategic plan, the first draft, in September of 2019. So I think as we began this work, and we didn't start from scratch. As Attorney General, Governor Mills and I had worked together for many years when I was my previous position at the Maine Medical Association. And so I think we realized that we needed boots on the ground, that we needed an army of people to really reach out and connect people who were struggling with substance use to something, connect them to the recovery center, to harm reduction, to a syringe program, get them into a treatment program, and when they're ready. And so we worked on this idea and then announced it in the fall of 2020. And it really had two components. It has a media component where we're sending messages to the public about, trying to break down stigma, frankly, trying to say, let people get help. And if you've got a loved one struggling with substance use, here's the number to call. Help is available. And then we hired 16 individuals to be in every county and to, again, particularly the original idea was based upon a model that started in Portland. And I think it's probably important to start there, that the idea was they would actually co-respond with law enforcement or EMS to an overdose.
Oh, I see.
Because, we were having a significant increase in overdoses, really right from 2015 right up till 3 years ago when they started the numbers starting to get better. And so the idea was, don't just go and revive a person, because even now and even then, the overwhelming number of people that overdose on drugs survive. 95 out of 100. Only 5% of our overdoses are fatal. That's still way too many, 390 people last year. But it's really important that we help and reach out to those people who survive their overdose. Because if they continue to use drugs, as dangerous as the supply is today, the overwhelming likelihood is that they will eventually die, that we will eventually not get there soon enough. And we've had, with the Naloxone, which we'll come to, we've had a really, successful, we've been really successful with a number of individuals who may have been resuscitated and revived from an overdose 10 or 20 times. And to the general public, I know that sounds ridiculous sometimes, that we'll have to fight that back. But to the governor and I, it's about keeping people alive to the point where they can get into treatment when they're ready. And why wouldn't we want to do that? Naloxone's a fabulously successful drug if the person is overdosing on opioids. So back to the beginning, the idea was that we would contract with 4 behavioral health organizations, and ask them to hire the people, because it's really difficult the way we do state budgeting to hire state employees to do the work
Right.
and
Yeah.
supervise them ourselves. So we contracted with 4 really strong partners in the behavioral health area. I mean, it happens to be Sweetser, Spurwink, the Rustic Mental Health Center, AMHC, and CHCS in Bangor, and all of which really been really strong partners 5.5 years. So we hired these would be behavioral health liaisons. They would have, they'd be an LADC or a licensed social worker, and they would, as soon as possible, reach out to people who had, because we were having 9 or 10,000 overdoses a year in this.
Wow.
So we started collecting data on how many people they reached out to, how many people they could reach. There are HIPAA issues. There are this is not easy work, and of course, people honestly, when they first are revived, or when we're successful in saving a person, that's not their first orientation. Is that, oh, I want to get into treatment immediately.
Right.
Their first orientation is many times they're angry because they were getting high, and we have, hopefully we haven't precipitated withdrawal so that they're in out of anger, really in agony physically. But it's really not always the best time to have the conversation. What you want to do is make a connection, and maybe the next day you talk to them. So they're always offered an opportunity to work with our behavioral health liaison. And I would say, we're successful probably less than half of the time in being able to reach. Number one, they may say, no, I don't want to talk to him. And they may not be able to give us the name because of HIPAA compliance. So, but we started collecting data, and we found that the program was definitely successful enough that we worked with the Attorney General, and really appreciated Attorney General Fry giving us the opportunity to do this. So that 2 years later, we doubled the number of liaisons from 16 to 32, so that every county has at least 2. And that's been really helpful. I would say, actually, there may be one county that's got like 1 and tag teams with the person in the next county. But it's been really good because now they can work as a team too. It's pretty tough out there. And we've had a lot of turnover, and we've probably never had a single day that we've had all 32 people on the ground. You hire 2 more, you fill a couple gaps, and you lose someone. Well, you're always going to, people are not going to deny them a chance to go to the next level if they get a nice opportunity someplace else. But we do try to do exit interviews and things so we understand what our liaisons need. And they do need a lot of support. This is a hard job. They're not paid enough. They're working with individuals that are really living chaotic lives, many of them. And they're working with individuals who may die, right? Despite the best efforts of the liaison. And interestingly and unique, many of them are embedded, most of them are embedded in law enforcement agencies, police department, sheriff's office. Why do we do that? Well, we do that because those are the first people that respond in Maine to an overdose. But because many of our liaisons are people with lived experience, that means that they may be embedded in a police department that, in fact, arrested them and incarcerated them 10 years.
Yeah, so they've been there, and so they can sort of relate maybe
Yes.
to the person who might need some help.
But that can also make it a difficult relationship.
Sure.
So we've really learned over the 5.5 years, I think, the support that the liaisons need. But the data that we've collected, that we put regularly on the Maine Drug Data Hub, shows that they have been able to get thousands of people, make connections, get them into treatment, connect them with with a syringe exchange, do something that's helping that person stay safe as they can be today. So we think it's been a great program. We also have a media connection where, as they say, we're now featuring a lot of our options liaisons in the media advertising. So it's not it's an expensive program to run, but we really think it's one of the things that's making a difference in bringing those overdose numbers down.
Absolutely. And it's such important work. And so I'm so glad that you're all doing that work. Um, can you, I want to talk a little bit about safer drug practices.
Sure.
So, to some people, safer drug practices sounds like an oxymoron.
Right.
What do you say to that?
It's basically acknowledging that if a person's addicted to substances, they're going to use substances until they get into an effective treatment program. We don't really believe in involuntary treatment. There are some states that are trying this. The president has suggested that this is the approach, just arrest people and force them into treatment. The mental health community, of which NAMI Maine is such an important part, by the way, does not believe in that works. I don't believe it works. I represented in my previous position the Maine Association of Psychiatric Physicians for decades, and they do not believe it works. So what are we left with? We're left with really thousands of Mainers who are using substances who we don't want them to die. We do not, because that's not just the death of an individual. It affects, in a large way, the entire family. It might affect their school. It might affect their workplace. But it certainly affects the family. And so we want to give them every chance to live and to have a chance for treatment and to have the joys of life that you and I may enjoy today. So if we're going to do that, harm reduction simply allows us to educate them in safe practice. It doesn't, in our opinion, mean that we're encouraging drug use. It doesn't mean that we're encouraging more people to use drugs. It simply means we're trying to work with that single individual to let them be the best version and the safest version of themselves that they can be. Maybe that's moving from injection to smoking. Maybe it's making sure they don't share a needle with someone else and infect another individual with hepatitis C, where we still have very high rates, or HIV. So, we believe in harm reduction, and we've been really disappointed to see the federal government back off from scientifically supported public health measures that help people stay as safe as they can that day.
And so you spoke about several different forms of harm reduction. One of them, Narcan, is something that maybe a lot of people have heard of, but aren't necessarily familiar with. So can you briefly just tell us a little bit about Narcan, when you might use it, how it's administered, how important it is?
Yeah. Narcan is the brand name for a form of Naloxone,
Okay.
which is medication that was discovered many years ago and is remarkably successful in reversing an opioid overdose. It has to do with the receptors in the brain, and we've got physicians and public health people and harm reduction specialists do a wonderful job of explaining why it works.
Sure.
What I know is the different versions of it. So Narcan is particularly popular because it's a nasal spray, and there's two doses in each kit, and you can buy it now in a pharmacy for about $40. We also, as I say, have used state funds, some federal funds, to purchase in the 7 years. We made the first purchase in August of 2019. So, as I say, before I finish this work in December, we will have purchased, no doubt, a million doses.
Wow.
And we know it saved over 12,000 lives.
Wow.
And so it very quickly works to reverse the effects of an opioid. Um, and it's a beautiful drug because it doesn't hurt anybody. I mean, if it turns out that the person's not is unconscious because of something other than a drug overdose, it's not going to hurt them any to, basically insert this in their nose, press the thing, and give them a dose.
Yep.
And then you wait 2 or 3 minutes, and then if there's still no reaction, then you give them the second dose. And it's just one version of naloxone. There's now competing versions. For instance, it's much less expensive to do it by a syringe and inject it. So, for instance, if we're working with people in our clients of a syringe program, of which there are several thousand people using our syringe programs, we would distribute to them the injectable version because they have no aversion to syringes. They're using them many times a day. So that's a different version. It's much cheaper. There's also now competing manufacturers, and that's good. It's lowered the price. So it's a miracle drug. It only works on opioids, but it doesn't hurt people that may be overdosing on something else.
So I think a related topic here is the Good Samaritan law. Can you just explain that a little bit?
Sure. Yeah, I'm on, as a lawyer, I'm probably on sounder ground talking about the Good Samaritan law than I am the administration of naloxone. The first law was about 2019, and then it was strongly amended in 2022. It was been touched up since, but it's considered the version that was enacted around 2021, 2020, might have taken effect in 2022, is considered the strongest Good Samaritan law in the country. Mm-hmm. And what it does is that it encourages people to call 911 when there's a suspected overdose, rather than to flee the scene because they're afraid of being arrested for possession of drugs. And so it's almost every state has some version of it, and it doesn't protect everything. I mean, it doesn't protect people who have committed other crimes, but it does protect a person who from being charged with drug possession because they call 911 and stayed with an individual, providing them perhaps with naloxone or otherwise staying with an individual. It was quite common, unfortunately, years ago for people to just flee the scene and leave the individual to die. And so it was really necessary to pass a law and to educate them. And we passed that with the support of law enforcement. You will sometimes find some law enforcement people that think that the law is too strong, and that remember what I said earlier, that the first people that show up at an overdose is law enforcement.
Right.
And that's just because they're the people that are available. We may have an ambulance coming from EMS as well, fire department, or from an EMS service provider. But usually police get there first. So the police are there. What are they there for? Well, they should be there to revive that person, not to be looking for who they might arrest because these people have been using drugs. Obviously, they've been using drugs. And so what is there can't be used to prosecute the people that are there. Now, there's a very important caveat. You have to be in some way assisting that individual. You either call 911, you stay with the individual, you give them Narcan. You have to show that you have somehow been assisting the individual who we suspect has had the drug overdose. The reason to be so clear about that in the law is that what if there are 10 people in the house,
Sure,
all using drugs? Well, if there's 3 people upstairs using drugs and 2 people downstairs, or are helping this individual, the law is not going to protect the three people upstairs.
Right.
So it's not perfect, but it is one more thing that I think has encouraged people that as good as naloxone is, we don't want people to, well, the first thing people should do is call 911.
Yes.
Second thing they should do is use Narcan or naloxone, and also they're trained to how to position the individual, and how to determine you do a chest rub and determine whether they're even overdosing. So, but again, I think the Good Samaritan law is an important piece of it, and we, there are also some provisions. There's some exemptions, like you're not protected if you've allegedly committed a crime against children, or there's certain
Caveats.
homicide.
So, speaking a little bit about law enforcement and
Yes.
medical providers, there is a concern, I think, or worry about those professionals, about the circulation of fake or harmful drugs like fentanyl and things like that. So, can you speak a little bit to that?
Sure. We work very closely with the law enforcement community. We enacted a strategic plan and then amended it, and that plan has a whole section about law enforcement and the supply side. We appreciate the role of law enforcement in this work. There are people, there are advocacy groups across the state, across the country even, that do not believe that anyone should ever be arrested for trafficking. I mean, that is an approach that's been tried, to at least decriminalize possession in some states and in some countries across the world. But the governor was attorney general twice. She was a first woman district attorney in New England. She doesn't. Her father was a Republican U.S. attorney. She does not have a natural tendency to dislike law enforcement. She's a lawyer. Like I said, she was a prosecutor. And so my signals have always been from her that, no, these are our partners. And when we have the summit each year, the Opioid Response Summit has been very successful. We have we bring in law enforcement and have their own meeting, and work closely with them. So they have seized more drugs.
Mm-hmm.
We work closely with the DEA, work closely with HIDA as a public health person, as well as a chief drug enforcement person. And, you can't ignore the supply side. It's a very interesting philosophical question that we think about all the time about, is it supply that's driving the demand, or is it the demand for drugs in this country that's really driving the supply?
A larger philosophical, complicated question.
We give it a lot. I've given a lot of thought. Read a lot of books about it. Talk to law enforcement. I think it's a little bit of both, frankly. But you don't want to ignore the supply side. You don't want to hold up a sign down in Kittery and say, bring in as much as you can. You have to do what you can to seize the drugs and keep them off our streets, even though law enforcement itself would say that on our best day, we get maybe 10, 20% of the drugs. So that leaves 80 to 90% of the drugs in the many different ways. People have I want to be kind here, not a political talk, but the notion that you can simply close a border, that's going to solve our problem. And I say, really? Because it seems to me I'm still going to be left in Maine with tens of thousands of people that are addicted to drugs who are then going to use something else. Mm-hmm. What we know they've done a great job in Massachusetts. They have a rapid response team. So if there's going to be a big seizure, they actually work with the drug using community so that they are aware that their source may be may not be available. Because what you learned is that if there's a big, throughout New England, if there's a big seizure and it really is effective in taking drugs off the street, actually our overdoses go up. And this is science. It's not that big a surprise when you think about it because because of what we said about addiction. People are addicted. If they're addicted, they have a severe substance use, they're going to use drugs. They will find whatever there is to use. And we learned about this in the pandemic, that if you disrupt that source, that they'll find another source that they may not be as familiar with, and it may be more dangerous.
So as we're starting to come to a close here, tell us a little bit about resources and treatment. One of the things that you've talked about today is how essential treatment is.
Yeah.
So
I think when we started in 2019, we'd had 8 years with a former governor who really didn't have the same approach to substance use disorder treatment, recovery. First we got to get people. We got to do the harm reduction piece. Keep people as healthy as they can. But when they're ready, I've always felt it was our really obligation as a state to make sure that we're ready when they are. And it's so important because your window of opportunity, man, woman, young mother, 10 o'clock in the morning, they call the detox center, they're ready to go. But then they can't get a ride. And then they have to call back again. And then now it's 4 o'clock, couldn't get in, they go and use it. They might die that night. So we really needed to improve access to treatment. Start with help with medically assisted withdrawal, what we used to call detox. At one time during the pandemic, we might have had as few as 20 beds, because again, single rooms. Pandemic was,
right.
lucky.
Whole other time.
Somehow we got through. So now we have over 100 detox beds, and they're not all full, and that presents other problems for us in terms of financing. But that's okay. I'd rather have too many beds than not. Then we have to have short-term residential. Person that helped to come off the medication, off the drugs in 5 to 7 days, most of them are not ready to go home. Most of them are not ready to go into a recovery residence, which is a residence. It's housing. It's not treatment. So we need short-term treatment, maybe 30 to 45 days. Then we have longer treatment available if a person at that point is not ready to go to recovery residence. So you've got to have the continuum of care. And if you fall down on any of those detox, you lose the benefit of detox, for instance, if we then don't have enough short-term residential beds. That's why we've worked with Milestone, probably our premier detox facility.
Yep.
Turns out we had 30 beautiful detox beds. They weren't full, so we let them take the detox beds to 10 and have 20 short-term residential. So now you go through your detox, and then you can stay there for another 30 or 45 days. So I'm very we still need more short-term residential, and we've got a 58-bed facility being built in Alfred by courtesy of the county commissioners in York, the county of York. God bless them. That's like building a hospital, 58 beds.
Absolutely.
And there'll be some detox, there'll be some short-term residential, some long-term residential. And we've got a treatment facility over here west of us in the town of Washington called Tessa's, which is for young women. They've got available, but it's a treatment facility. It's not a recovery residence. So we've really added a lot of beds, and probably still need some more in some of those categories. But then we really want to support people in their recovery. We know that relapse is a part of the disease, and so it's not a failure really when that occurs. It's just a very difficult illness. And again, then you want to work with the person. That's why we want to support people in their recovery for the rest of their life. And so we do have a lot of resources that go into that phase as well. But I'm really proud of what we've done. We've got more to do. Our job now, I mean, the governor and I will not be in these positions beyond December. She may do other things. I'm
Sure.
going to play with my grandchildren. And so this year I'm really committed to creating the more infrastructure so that these projects, like the option, have the best chance of going forward, regardless of who the next governor.
Wonderful. Well, thank you, Gordon. Really appreciate all of your insights. Check out knowyouroptions.me for more info on the options program. And of course, NAMIMaine.org has mental health resources as well. Help is available. I think that's really important to highlight. And hope is prevalent. And I think it's all of our jobs to create that hope in our communities.